Thank you, respected chairpersons and dear colleagues. So the main work of this talk is done by a group of surgeons and histopathologists across 3 centers. I've just claimed co-authorship by adding one of a few slides from a series of paper that we'd published. So as we all know, paragangliomas are neuroendocrine tumors. Significant amount of these can be malignant, and out of the head and neck tumors, head, chest, and abdomen, about 0.5% are paragangliomas, out of which the head and neck are higher. Somatostatin receptors, as we all know, are G protein coupled receptors. They are overexpressed in neuroendocrine tumors, particularly somatostatin receptor 2A and 5, as we've seen in gastroenteropancreatic neuroendocrine tumors. They can be imaged with gallium-68 DOTA peptide-based PET-CT. Several treatment options have been worked up previously. Medical, which is octreotide, lanreotide, and everolimus in pancreatic NENs. And currently, obviously, we all know over the years, PRRT is another treatment option. With regards to chemokine receptor CXCR4, Professor Lassman has already discussed extensively about that in the previous talk. But what's important is that, yes, they are associated with their involvement in tumor progression, and they are seen in, when the tumors are more metastasized or higher grade, and they are patients whose tumors express CXCR4 are associated with reduced survival. So in this series of patients, retrospective analysis was performed on 54 formalin-fixed paraffin embedded samples, out of which were obtained out of 43 operated patients. As said earlier, this was shared between 3 centers. Immunohistochemistry and PCR analysis, mainly using monoclonal somatostatin receptors and CXCR4 antibodies, was performed. And staining was rated by immune reactive Remel and Stegner scores. The most expressed receptor subtype in this group was somatostatin receptor 2A, followed by 5. And 2A presented strong staining with more than 10 IRS points, and all others were relatively less. And this was also confirmed or validated by PCR analysis. Some of the results, there was no staining seen for SSTR4. There was mild positive staining for 1, 3, and 5, but intense staining for somatostatin receptor 2A. With regards to CXCR4, the expression was seen on tumor cells, only in few cases. However, the vessels expressed more CXCR4 in all cases. So just to, one of the papers that we've published is the PRRT with yttrium and all lutetium labeled peptides for inoperable head and neck paragangliomas. So this was to assess the molecular, morphological, and clinical response of inoperable head and neck paragangliomas. There were 9 patients over a course of several years, 4 with solitary lesion, 5 multifocal, of which 4 had no distant metastasis, but 1 had distant metastasis. Pre-therapy confirmation of somatostatin receptor expression was assessed by gallium-68 DOTA PET-CT. 2 to 4 cycles of yttrium or lutetium labeled peptides based PRRT was performed. Assessment of response to treatment was performed with serial imaging 6 monthly with gallium DOTA PET-CT and symptomatic response for clinical assessment. 4 patients showed a molecular partial response with decrease in SUV max, but also some tumor showed reduction in the size. 5 patients had stable disease. With regards to clinical response, 6 patients who were symptomatic before therapy. Of these, 4 patients had symptomatic improvement, but with 2 it persisted. This is one of the cases where you can see on the MIP image, this bulky mass here involving the right skull base and extending inferiorly with two foci in the contralateral skull. Sorry, let me get the cursor. Here, base and cervical region going down. Then in the mediastinal region, you could see, and there was a bit just faint uptake below the thyroid. And out of the both jugular foramina, right had more uptake than the left. They were distant. This could also be seen. This is the picture on MRI of the right-sided bulky tumor. With regards to distant metastasis, you could see a left lung nodule. There was in the left ninth rib, there was uptake, and there was uptake in the thoracic vertebral body. Same patient. This is the brain-stalling imaging post atrium 90 DOTA talk. You can see uptake in the large bulky tumor. So these are the pre-PRRT images, and this is post 3 cycles. Here, I mean, you can actually see reduction in the size of the bulky tumor, and as well there's reduced uptake in the vertebral body lesion. So to conclude, in this group, or at least in this series of patients, PRRT seemed effective. There was no disease worsening or progression. Although these are preliminary results, PRRT showed that it holds promise as a treatment option for inoperable head and neck paragangliomas. And of course, a study in a larger cohort as possible would be reasonable. So to summarize, somatostatin receptor expression in paragangliomas, the sporadic and SDH DPGLs express somatostatin receptor 2A, which was this group of patients, and gallium-68 DOTA peptide imaging plays a significant role in patient selection and also then for follow-up. And PRRT with DOTA peptides appears promising. Again, with regards to CXCR4, the paragangliomas, the CXCR4 was seen mainly in tumor vessels, and with regards to this, CXCR4 antagonists may prevent actually vascular metastasis or angiogenesis. However, further studies are required. And thanks to the collaborators.
Did you have a chance to, I think you didn't, but do you have an opinion on norepinephrine transporter 1 levels? Do you plan to measure those in these tissues, and or did you select a group that you knew were MIBG negative? We struggle sometimes with what agent to use in these cases. In the U.S., sometimes MIBG would be the agent of choice.
With regards to treatment?
No, well, at least diagnostically, and I mean, diagnostically and therapeutically.
Yeah, I mean, because we are already practicing PRRT, and we can, and then based on the immunohistochemistry that we have performed, especially seeing that somatostatin receptor 2A is well expressed, makes sense based on previous PRRT experience with neuroendocrine tumors to use DOTA-based peptide for imaging and then therapy. That was our logic for it.
I don't want to dwell on the same theme, but I think that would be fair to have a head-to-head comparison to identify whether MIBG, which perhaps in Europe and in Germany in particular, given the label we saw on 31, would be much more cumbersome to do as a treatment than yttrium lutetium.
Yeah, I agree to that, but that's something to work on. Yeah,
Other comments? Thank you very much.